Good afternoon, and thank you everyone for being here on time. I can see that we have a few people who are still signing on, so I'm going to leave it 1 or 2 minutes before we get started. Thank you. Good afternoon or good morning, depending on where you're located, and welcome to this wonderful virtual town hall discussion. My name is Sarah Jane Rapp, and I'm a curriculum developer and trainer for Primary Care Development Corporation, commonly abbreviated to PCDC. We are really excited to have you with us. We have a great webinar and some super panelists and questions to keep you interested and informed. And we hope that you will participate in this important topic of discussion. Just a little bit about Primary Care Development Corporation before we get into the town hall discussion. Next slide, please. Primary Care Development Corporation, PCDC, is a national non-profit organization and a community development financial institution catalyzing excellence in primary care through strategic community investment, capacity building, and policy initiative to achieve health equity. PCDC's capital investment team invests in communities by providing advisory services and responsible, affordable loan capital. We are uniquely positioned to provide financing that is tailored to transforming and expanding primary care. PCDC's performance improvement practice partners with providers to help them understand their opportunities and challenges and develop customized strategies to achieve their goals and sustain improvement. PCDC also works with primary care providers, policymakers, industry leaders, and other advocates to advance policies that increase access to quality primary care, enabling it to more successfully improve health outcomes, reduce costs, and improve health equity. We have 3 locations. We have one in New York City, DC, and LA. Next slide, please. And these are the 3 arms of our work: capacity building, capital investment, and advocacy. Next slide, please. So let's have a look at the town hall agenda. We plan to discuss what's happening in our communities and hear directly from you and our panelists about the impact of COVID-19 on our current environment. Our panelists will share challenges, successes, best practices, and resources. Next slide, please. Here are the learning objectives for today. Discuss the impact of health disparities on COVID-19 health outcomes. Describe ways to address staff burnout. Examine health center sustainability. And identify individual experiences of COVID-19. Next slide, please. So at the end of the webinar, we will ask you to please complete an evaluation. You will receive within 24 hours a link to our website to access a copy of the slides, a link to the recorded webinar, and some PCDC resources, and the panelists' bios and contact information. We ask that you use the Q&A box for any questions you might have in response to the panelists and their questions. We will be monitoring both the Q&A box and the chat box. If you have comments on responses to the questions or concerns, please feel free to use the chat box. You will be muted for the duration of the webinar. This webinar is being recorded. This town hall is a shared experience and a conversation about what's going on with staff and in your communities. Please share comments or questions. We would love to hear from you all. Okay, that's it with logistics. Let's trot on with the polls and find out more about you and who is attending this town hall discussion. Next slide, please. So we have a poll up here. We would love to know what's your primary professional area. So if you could just complete the poll, click on it and send it back. We will see the results in a minute. Okay, I'm going to give you a couple more seconds. Okay, Mike, can you show us the results? Okay, lovely. Gosh, a lot of healthcare administration, management and leadership. Great. Oh, we've got a lovely selection here. Social services, academia, outpatient primary care, or outpatient behavioral health care. Thank you, that's lovely. And we've got a second poll because we'd like to actually find out a little bit about how you're feeling and coping today. So how are you? We would love to know. Okay, I'm going to give it a couple of seconds. Okay, thank you. Can we have a look at the results, Mike? Yes, a lot of you are tired. I'm not as effective as I usually am. I'm here, but my mind is somewhere else. I'm not finding it any more difficult. Interesting. Yes, we've got a large percentage who are on it. It's hard to focus. I'm not as effective as I usually am. I'm here, but my mind is somewhere else. Thank you. And a lot who are tired. Thank you so much for completing the polls. It's nice to know and to see and to gauge where people are. I'm now going to introduce my co-worker, Henrietta Crosswell, who will be facilitating the next section. Henrietta is Program Manager for the CDC HIV Prevention Grant at PCDC. Thank you so much.
Thank you, Sarah Jane. Hi, everyone. Good afternoon. I'm very happy to be here today to be part of today's conversation and town hall webinar. Again, my name is Henrietta Croswell, and I will be joined by my colleagues, Kristen and Judy, in a few moments. Next slide, please. When the COVID-19 pandemic entered our community in the first few months of 2020, most of us were filled with uncertainty, fear, grief, and sadness. Many of us lost loved ones, jobs were no longer available, or people were laid off. School, places of worship, workplaces were closed and moved to a virtual environment. While essential workers remain on the front lines to support businesses in healthcare, law enforcement, fire departments, grocery stores, pharmacies, and transportation. In a parallel form, the spirit of hope and resiliency also started to take shape as communities talked about how can we flatten the curve of COVID-19. Staying home, practicing physical distancing, face covering, Zoom meetings, Zoom parties, and driving by and waving to friends and families became our norm and part of our daily conversations. Unfortunately, not too long after, an unprecedented and deadly curve began to take shape in February, March, May, and June. The names of Ahmaud Arbery, Breonna Taylor, George Floyd, Tony McDade, Rashad Brooks, Dominic Remy Fells, and Rion Milton became household names along with others who were no longer here. The voices of the unjustly treated, the voices of families, voices of communities began to rise up in the name of police brutality, racial profiling, community profiling, structural and institutional racism in our educational, criminal justice, and healthcare systems. Protests across the globe in the name of justice for Black and Brown communities, justice for people who remain unheard and who are disproportionately affected by COVID-19. During today's town hall webinar, we hope to be part of an ongoing conversation about how COVID-19 impacts healthcare providers and organizations while considering the intersection of social injustices and social determinants of health continues to plague our communities. We will identify, discuss, highlight ways we can remain resilient and keep hope and faith during these times. Next slide, please. So let's take a look at some of our current data in the United States. As you can see here on the CDC COVID-19 webpage that we'll get to in one moment, really highlights the current data to date. As you can see right here, if you can just go right back up, Mike. Yeah, right here is good, thank you. As you can see, as of June 22nd, which is as of yesterday, the United States has a total number of 2,275 cases to date. And of those cases, 119, almost 120 were the total deaths. And as you further scroll down on this website, right here you see a map that really highlights the concentration of those cases. As you can see in the northeast area of the country, the eastern part, and as you can see, the southern part of the country, in Florida and Texas, and also in the western part, are where the cases are highly concentrated. And as you can see, if you look on the right-hand side, the darker areas indicate where there are 40 or plus more thousand cases in those particular regions. And if you see on the bottom there, this map also indicates that US territories are also included, such as the US Virgin Islands, Puerto Rico, and Guam. And as you scroll further down on the site, if you just go right back up a little bit, Mike, you can also click where you see jurisdictions, and you will be able to click specifically on your particular state in where you can find out more specifically where, where your regions are, and then more specifically your county. And as you scroll further down, right here, where it talks about new cases by the day. And as you probably all heard over the last few days, the number of cases has started to go up in the last few days. And as we note, as we begin to reopen in many parts of the country, those number of cases have started to rise. Some of the cases that were significantly highlighted included states in Arizona, Florida, and also California. However, as early as of this morning, they also indicated that there's been an uptake in cases in more than half the states across the country. So we can get out of this slide and go back to the PowerPoint. Thank you. Yeah, and I think the only other piece that I want to highlight here is just for us to be mindful of the fact that as we begin the reopening phases of a lot of the states, we want to continue to pay attention to the numbers that are going up. And then more specifically, there also are various state demographics that are being collected that are not consistent across all states. So those are other things that we want to also keep in mind. So now I think I'm going to turn it over to Judy and also Kristen, and they're going to begin our panel discussion. Thank you.
Thank you so much, Henrietta. And just want to make sure all the panelists are on camera. Thank you. My name is Judy Lipschutz, and I'm a Senior Project Manager here at PCDC. It's a pleasure to be here with you today to discuss this unprecedented time in our nation's history. I'd also like to introduce my PCDC colleague, Kristen Potterbush, who's the Program Director of the Center for Sustainable Strategies funded by HRSA here at PCDC. We will both be moderating the upcoming panel focused on the impact of COVID-19 on healthcare providers, healthcare organizations, and the communities we work and live in. I'm going to start by having each of our esteemed panelists briefly introduce themselves while they're answering the first questions. In the interest of time, we're going to keep that short, but I want to let you know that each panelist's extensive bio will be sent to you following the webinar. So let's get started. Our first question, while you're introducing yourself, is to provide a brief description of the impact of this pandemic on the care that you provide. And I'd like to start with you, Dr. Kohal, if you could kick it off for us.
Judy, thank you so much. I'm honored to be here with you all today and sharing some of the work that I and others are doing. So I wear many hats. For example, I run one of the 8 CDC funded STD prevention training centers. These centers are charged with enhancing and improving the skills of primary care providers in working with clients who have STDs. We have a large region. Our program encompasses New York, New Jersey, Ohio, Indiana, Michigan, United States Virgin Islands, and Puerto Rico. I'm also a clinician at Columbia University Irving Medical Center, and I oversee programs that serve young people living with or at high risk for HIV. At the hospital, we have comprehensive integrated medical case management and psychosocial services for young people living with HIV. And in the community, we have a very aggressive outreach program that goes out into a variety of settings and provides pop-up clinics which screen young people for STDs, HIV, and hepatitis C. Additionally, I'm a medical consultant for PCDC in their various initiatives regarding HIV care. So, as Henrietta mentioned, COVID has turned our world upside down. Specifically for my programs, our community outreach initiatives have been shut down. But fortunately, we've been able to pivot and explore new ways of connecting with young people, and I'll talk about that a little bit later. In terms of our clinical programs, we've had to drastically reduce the scope and services of our HIV care. We are at the point now where we're beginning to plan for a soft launch and reopening, but for several months we've been limited to seeing patients virtually and seeing only the most acute or most sick in our clinical care settings. I'm sure many of you have experienced similar scenarios. The issue before us becomes, how do you provide support for a cadre of very high-risk patients, which is difficult enough to do under normal circumstances, and now you have a pandemic thrown into the mix. So let me share with you a case that I think illustrates some of these concerns. About a month ago, I got a text from one of my young adult patients who's MSM on PrEP, and he was complaining of rectal discomfort. While our clinic had limited capacity, fortunately our labs were open and I was able to get him to come in and do self-administered screens for STDs and get blood work done. As it turned out, the next day I got a notification that he had rectal chlamydia and also had syphilis. So much for social distancing. Fortunately, his HIV test was negative. I was able to get him back in, get him treated, and I encouraged him to talk to his partners and inform them about the results and to get them treated as well. This was difficult as many of these sexual health clinics run by our Department of Health have had limited capacity or in fact were closed. In any case, about 3 weeks later, I got another text from him with other concerns, and we arranged for a telehealth visit that afternoon, which was a Friday. Turned out that he had been having fever for several days. He took it upon himself to go in and get tested for COVID, and that test was negative. However, due to his prior history, we both had concerns about other issues such as HIV. So I got him into the lab that afternoon for testing. The next morning was Saturday, and as I woke up, I said a silent prayer before I checked his results. Unfortunately, this time the HIV test was positive. So we arranged for another telehealth visit to review those results. And it was so very, very surreal. Over the years, I've had to tell hundreds, thousands of patients about their HIV status, but it's always been in person. And that's so important. So you have the capacity to offer a tissue, a touch, a hug. This time, there was substantial distance between us, and it felt very disembodied. But in any case, I spoke a little bit. I told him about his results. I gave him some information about what the next steps were, and really offered hope because of the new advent of improved antiretroviral therapy. But I think the most important thing I did was listen. And what he told me was one of the most heart-wrenching things I have heard, not only over the last few months, but over the lifetime of my career. He mentioned that a couple of months ago, his brother died of COVID. Now, different people deal with grief in many different ways. In his case, it affected his adherence. It also spurred him to seek comfort in the arms of other people, to get distance away from his pain and suffering. So when we think about the impact of COVID, clearly there's an impact on those who are infected with COVID, but we also have to keep in mind about the secondary impact on those family and friends of people who have succumbed to the virus. In any case, I squeezed him in the next week for an appointment. He had 4.8 million copies of HIV virus running in his system. So clearly this was a case of acute HIV. We got him on meds, and hopefully in a month, he will be undetectable. He's also getting virtual mental health counseling, and I check on him every couple of days. He is seeming to regain his balance. And in fact, the other day I got a text from him wishing me well for Father's Day, which was notable given all that he's been through and all that he had on his plate. So we could talk more about this case during the Q&A period, but I wanted to highlight a few key points. One, communication between providers and patients is so crucial, especially given this crisis situation. Conducting telehealth visits would have seemed to be a pipe dream a year ago, but now it's become an integral part of how we do our work. Number two, even though the healthcare delivery system is in tatters, we were able to cobble together enough pieces to get him tested and treated for chlamydia, syphilis, and HIV. Number three, despite public calls for social distancing and sheltering in place, the need for intimacy sometimes overwhelms policy and pragmaticism. So as we're working with patients, we need to inquire about their sexual health, about their mental health, in addition to their physical health. And the last point, we're all caught up in COVID. We think about COVID anytime we see a patient, particularly with respect to someone with fever. But it's also important to consider other factors, such as acute HIV. The old problems have not gone away. So let me stop here and throw it back to Judy.
Thank you so much, Dr. Kohol, for framing our discussion today. Next, we're going to go to Barbara Warren. We'll ask you the same question to introduce yourself and to tell us about the impact of the pandemic on the care or you provide or the work that you do.
Thank you. Hello, everyone. Some of you will notice that I have a very colorful virtual background. I hope it's not too distracting. I thought about turning it off, but when we did a run through last week, everyone said, no, leave it on. And so I left it on. Some of you may be aware that it is Pride, LGBTQI Pride Month nationally, and it's LGBTQI Pride Week in New York City, where I am located. And I am the Senior Director for Lesbian, Gay, Bisexual, and Transgender Programs and Policies in the Office for Diversity and Inclusion in the Mount Sinai Health System in New York City. I'm also an Assistant Professor of Medical Education at the Icahn School of Medicine. I teach residents, I teach undergraduate medical students. My focus is on LGBT equity and inclusion in the system in education, but I also do other work around our anti-racism initiative and all of our diversity initiatives. And I'm also a psychologist, and I do have a practice of psychology, not through Mount Sinai, it's private practice, but I do some behavioral health teaching and consulting within the Mount Sinai Health System as well. And just to echo Dr. Kohol's presentation, you know, we're one of the largest providers of healthcare in the greater New York area. We have 8 and soon to be 9 hospital systems as part of the whole Mount Sinai Health System. We also have one of the largest GME programs, residency programs in the country in general medicine. We have 2,600 residents across our system. We have a medical school, a biomedical research institute, and a very large primary subspecialty and ambulatory care system in addition to the inpatient system. So there are a lot of services that we offer, and I don't think there's any corner of the services that have been untouched and impervious to the effects of the coronavirus. I want to talk a little bit, Dr. Kohol did a great presentation on the effects on patients. A lot of the work that I do is around consulting, education, and training of our employees across the system, and that is everyone from security guards to surgeons around patient-centered care, and particularly with a focus on LGBT, culturally and clinically competent care. But I want to talk a little bit about the really powerful impacts on our employees, on our staff. And just a few things that I wrote down about what our folks have been going through, our employees in the Mount Sinai Health System. We have, by the way, we have 55,000 employees across all of our sites. Lots of them got redeployed right from the beginning, and they were amazing. Their call to action to really turn their attention fully to COVID and the incredible work that they did addressing that and saving people's lives. But it was really, really stressful to do that. A lot of people were redeployed from, for example, primary care sites to being on inpatient wards with patient acute respiratory distress. And they had to learn new things really fast, and they had to go back to some skills they might not have practiced since medical school or residency. And that was across the board with nurses, with techs, with physicians, with all the folks that have to attend to patients, particularly during an acute healthcare crisis. Some of our non-clinicians were also redeployed. Also, a lot of them, subsequently, we suffered a lot of income loss because we also had to, like Dr. Kohol said at Columbia, cancel elective procedures and just go to full-on emergency. We had a number of months, about a month and a half, where every single one of our sites were inundated with COVID patients, and people were in the halls. We had to set up tents outside all our hospital sites to accommodate people. So I could go on and on about the impact of this across the board, but I think it really, really was incredible stress. And people had their own personal experiences of getting sick. We've had some of our beloved staff die during this epidemic because they contracted the virus in service to our patients. worried about their families. It affected things like transportation, getting in and out of work. They didn't have, particularly frontline providers, didn't have the luxury of working from home. Some folks did telehealth. A lot of people were in there redeployed, taking care of patients directly. Housing, food, hours. We had to build respite areas for people. We had to get hotel rooms to have our staff be able to sleep there so they wouldn't have to do long commutes and further risk themselves or their families. Sometimes when they were exposed, they had to be separated from their families for 14 days. And so just the impact was extraordinary. There are positive sides to this, which I'll talk about, and a little positive things that came out of it. I'll say in terms of my job, and I'm going to talk a little bit later on about the particular impact that it's had on our LGBT programs and policies and patients, and what we've been doing around that, and also talk a little bit later on about the intersection between the virus and what happened around the anti-racism initiative that we already had in place at Mount Sinai, but how it really ramped it up and took it front and center off the back burner within our system, and the intersection between that and the work that I do around LGBT equity and inclusion. So thank you, and I will be speaking again in a little while.
Yes, thank you so much. Next, we'll go to Andrew Phillip.
Sure. Thanks, Judy, and hi, everyone. I'll be quite brief. I'm the Senior Director for Clinical and Population Health here at the Primary Care Development Corporation. You've heard a little bit about PCDC earlier today, so I won't go into too much detail. But in short, our area, we're really, we strive to be a voice of primary care and really kind of hold up a mirror. And so the things that Drs. Kohal and Warren have described are similar to what we've been seeing in our national work. We have just in our training and consultation work alone, we span about 37 states, and we're trained over 10,000 healthcare staff. So, seeing similar things as an organization, we've been working to do everything from getting PPE out to primary care practices to extending capital support, to also thinking about the work we do with our great teams here, our work around HIV integration, as we've heard some about, around incorporating behavioral health in primary care. We know that now, really more than ever before, whatever access point someone is using to get their care may be their only access point. And so really trying to think much more broadly about what that means, especially in primary care and behavioral health, which tend to be those kind of critical points. Just briefly about myself, I'm also a clinical health psychologist in addition to my work at PCDC, and actively see patients as well. Work as a trainer, also faculty, teaching on integration and some other things. But, what I've also just seen in my own work, and we'll talk about this more later, just the change in the delivery of care. We've talked about in the past things like delaying, things like, like testing, like we've heard about, even around diabetes and things like that too. But the actual delivery of care is getting so different in addition to all the problems we've heard about. I have patients who are taking our meetings in the car, out in the yard, hiding upstairs while someone else is listening to headphones. There's fundamental shifts that are really causing us as a field to change. And not to mention the struggles that healthcare providers themselves have been going through, which I think are profound, and we're really just seeing the tip of the iceberg for. So overall, we're concerned about just primary care and behavioral health practices keeping their doors open, the providers who are providing the care staying afloat in all of this, and then of course continuing to really put action where our mouths are as far as creating health equity and comfortable environments of care.
Thank you so much, Andrew. And next we'll go to Tamisha McPherson.
Hi, good afternoon, everyone. My name is Tamisha McPherson, and I am the Executive Director of Upper Room AIDS Ministry at Harlem United, which is a subsidiary of Harlem United. And I'm also the Chief External Affairs and Development Officer at the agency. I've been at Harlem United for about going on 10 years in different roles. Outside of Harlem United, I'm a national consultant, and I've on and off taught classes on a national level at various universities. How I would answer this question in regards to the impact of the pandemic for an agency like Harlem United has been an experience. That's the easiest way to say it. I was here daily through the pandemic from March and April. We didn't close, we're essential business. The pandemic has modified the method in which services are delivered. We are an agency, we have programs that are not only open 24 hours a day, which we have over 900 units of housing, but we also have an adult day program with about 250 clients that come or can program to come daily that have provided food for during the pandemic. So we had clients coming out, even though we were in the middle of a pandemic, coming to pick up breakfast and lunch. And I'm just sharing that to share with you the client population, which is definitely the underserved. And it was a transition for us to really transition from seeing patients that we see that day program. People are allowed to come 7 days a week if they're approved to come, to now not coming at all and going into depression. So with that said, our behavioral health numbers have increased tremendously, but we also had to transition from seeing patients face to face with a very limited time to have 50% less staff on site with limited even laptops. And I'm just sharing real examples of what we had to do in a few days, and actually work with clients that were used to seeing patients, seeing our providers face to face, and explaining how to even use their phone to go into a platform that we had to actually work on with the client over the phone and sharing with them. And that's the clientele that had the smartphones. The ones that didn't, we had other challenges. The other thing I will say that we have noticed during the pandemic, though, is the just all from providers to support staff across the agency have not only stepped up, really understanding our client population and meeting clients where they are. We are a harm reduction agency and meet clients where they are, but I will tell you it's a lot more challenging to speak to someone over the phone, especially if they're high risk. And I'm going to use a real example of they don't want to live anymore because they don't know what's going to happen tomorrow. We don't even know if Harlem United is, I mean, these are real examples. We don't know if Harlem United is going to be open tomorrow. You know, what can you do and how can you help me keep the stress down? But that is what I would share with you in regards to the pandemic. As I said, we were not closed. We actually transitioned from face-to-face visits to telehealth within a week, and deploying, I want to say almost 200 staff to work from home, which is not easy as well. But we did it. And I will share some more information later on in the presentation.
Thank you so much, Tamisha. And last but not least, Allison Connolly-Flores.
Hi.
Can you hear me? Okay, great.
Yeah, I hear you.
Okay.
So I'm the Chief Medical Information Officer at Urban Health Plan in the Bronx. Urban Health Plan is a network of federally qualified health centers. We have 11 health centers, 1 mental health center, and 12 school-based health clinics. And as I mentioned, we're in the Bronx, Corona, Queens, and also in Central Harlem. So I'm also a provider for the past 20 years in the HIV clinic. So I think this has been really difficult time, but also a really exciting time, because I think it forced us to do something very quickly that would have taken probably years to do. So basically overnight, in order to deal with the crisis at hand and to continue to see our patients and to stay financially viable, we had to switch to telemedicine. So we had to get, similarly to Harlem United, we had to get over 180 providers seeing patients remotely and using telemedicine basically overnight. So we did it in a couple of days. We're now in the process of being able to go back and relook at what we did and try to design a more robust telemedicine program. The other reason I think it's exciting, doing telemedicine or having telemedicine visits, I think it gives us a glimpse into a patient's life that we never had before. I was called the other day by a health educator whose blood glucose was low. They were diagnosed the day before with diabetes. I was able to have a video call with the patient, who also included his wife. And we literally opened kitchen cabinets. We were looking at food. I was educating him on what he should eat, what healthier choices might be. And I think just having that glimpse into the patient, into their daily life was really, really helpful. And having the opportunity to speak with his wife and his daughter in their kitchen, I think is just a new and exciting way that we'll be able to help improve people's lives. So I'm excited, and I'll get into some more specifics later.
Thank you so much. I think the whole telehealth world and Zoom world has brought us all much closer to each other and each other's kitchen cabinets and dogs. And it seems like that's a real positive in most instances. It's been really interesting. So I want to thank you all for your introductions. This amazing panel shows us the depth and the breadth of the many heroes that are working to continue providing care to patients, clients, and communities. And we've also had a few compliments as we go along, in particular, Barbara, for your beautiful background. Just want you to know that's been noticed and complimented. So I'm going to now hand it over to Kristen for the next question.
Perfect. Thank you, Judy. And thank you all again so much for the service that you provide every day and for taking that time to be with us on the call. And likewise, same compliment to our audience. So Allison, I actually want to go right back to you for this question because we want to sort of dive into the specifics around what's changed and sort of how the roles of staff has changed in response to the pandemic at organizations. And so, I'm curious if maybe you could expand on sort of what telehealth has looked like, during COVID and what that's looked like for the role of staff in terms of workflow and also in terms of other sort of provision of services, maybe such as pharmacy or lab, sort of how that's being woven into sort of the remote provision of care.
Sure. So I guess I could answer it a few ways. So one thing that we did is really try to reach out to patients. So we did, as soon as COVID started, we had a huge uptick in the number of phone calls we were getting on a daily basis. We were probably getting somewhere over 1,600 a day. So we quickly created a virtual call center, in essence, a virtual walk-in clinic, in essence. So patients would call, we would put them on a template, and the next provider available would grab that patient, and we were trying to triage them and just make sure everybody had their problems assessed in a very, as close to real time as we could, and seeing patients as quickly as we could. We then went back and tried to outreach to patients that maybe weren't calling. So our higher risk patients, our diabetic patients with very high A1Cs. And we tried to recreate a team-based model using telemedicine. So the pharmacist would be the first person to reach out to the patient. They would educate them on the medication. They would then hand off the visit to the clinician. And then the clinician would tie in the health educator and the nutritionist. So we really tried to replicate a team-based care approach with the telemedicine visit. That was sometimes more comprehensive than we could do in person because we were just able to coordinate somehow a little bit easier with all these people. We also had to redeploy different people. So because of the huge volume and influx of calls, certain people became call center agents. We had nurses also outreaching to patients because we were sending, as I mentioned, outreach texts to different populations, seeing if they needed care. They had the ability to text back to us. As soon as they did, we would have a nurse reach out to them so we could handle their concern appropriately, either schedule them with a patient with their regular provider or schedule them with one of the on-call urgent care providers that were seeing patients virtually.
That's phenomenal. I think that it speaks to sort of the flexibility that is inherent in a lot of the roles of healthcare providers. One day you're conducting one type of service and then the next you're a call center, sort of role, making sure that folks are being linked into the providers who are available. I think all of us are really curious around how models like the one that you described can be of service moving forward, whether COVID continues to be a major impact in our care or whether something else comes up in the future. I think a lot of us are really hopeful that the kind of model that you described today, Allison, is one that continue to push us forward into the future and help us meet people where they're at a little bit better. Thank you so much. Judy?
Yes, thank you so much. I'm going to direct the next question to Dr. Cole. As healthcare providers, we're used to being flexible, thinking out of the box, changing course, and following the science. With this in mind, are there any innovations that have emerged during this time? And if you could describe them, and which do you think might we benefit from if we're able to sustain them?
So thanks, Judy. Yeah, I think, those are the key words, being flexible and being adaptable. As I mentioned earlier, we have this very aggressive community outreach program. And what we have been doing in the past is going out to alternative high schools, colleges, community colleges, workforce development programs, programs serving the formerly incarcerated, and agencies serving LGBTQ youth. So clearly, we've had to put a lot of that on hold because our partners have not been operational. So one of the things that we have done to kind of address this, because clearly, as I mentioned earlier, young people are still in need, they're still involved in high-risk activities. We've kind of pivoted to using phone and email to reconnect with our patients to check in on them during this crisis. And, what we've also done is develop a home access testing program. So my wife, Renee, who's a clinical social worker who runs our program, along with the New York City Department of Health and our colleagues at New York Presbyterian Hospital, Kerry Carnavale, Paul Richards, and Jason Zucker, developed this initiative. So what we do is we have our health educators call up our clients, check in on them, conduct a risk assessment that not only assesses their sexual health behaviors, but also how they're coping with COVID, what issues they may have with mental health and substance use. And then if they're interested and if it's warranted, we will mail them a kit. And that kit consists of a home oral HIV test, STI test for oral, rectal, vaginal, and urethral swabs, and so on. So the health educator will review the kit with them. They'll be on the phone with them as they do the HIV test. They'll walk them through how to collect the samples. There's also written and visual instructions as well. And then those samples get mailed back to us, and we process them at the hospital for results. So what we found is over the last couple months, we've just started the initiative. We sent out about 200 kits. We've gotten about 85 of them back. Fortunately, we've had no positive HIV tests, but we have had 9 clients test positive for STDs. So this has been a very labor-intensive, but also a very gratifying initiative, particularly as we connect with patients who feel very isolated and alone. For example, we had one young woman that we connected with who not only was concerned about COVID, but also the unwarranted killings of Black men and women over the last several months. So to cope with her anxiety and grief, she had to drink heavily each night to get to sleep. So we were so concerned about her mental health that we delayed HIV testing her and essentially got her linked to one of our social workers for a home mental health visit. And in turn, she got linked to psychiatric care for services. Additionally, while our primary focus has been on STIs and HIV, we've identified a number of young women who have been at risk for unintended pregnancies. So we've been able to get them on Ella and birth control pills and NuvaRings and so on to essentially put their control back into their hands. So we think in the future, even if and when things get stabilized, this type of home outreach may have particular utility for many of our clients.
Thank you so much. Before I turn it over to Kristen, I want to just encourage you to, as we go along, if you have any thoughts or comments or experiences related to these questions, please chat them in and we'll try to intersperse them. And also remember to ask questions, which we're going to have a final Q&A at the end. Okay, Kristen, handing it over to you.
Thanks, Judy. So I think next we're actually going to break things up a little bit with a poll. Mike, are you able to launch that for us? Perfect. Thank you so much. So I think everyone should be shortly, there you go. So if folks could just take a minute and respond to this poll, there'll be another one right after it. And this is actually going to inform the next question that we're going to be speaking about further. But we know that, you know, sexual orientation and gender identity information is not necessarily collected laterally across all of our organizations. And this is something that we are, many folks are aware of, and I suspect a lot of attendees on today's event are attuned to as well. And as we move forward as a field and as we reckon with situations such as COVID, it's becoming more and more apparent how desperately important it is to collect this type of data. I think there have been some amazing town halls that have been conducted around the Black Lives Matter movement that have been discussing how demographic information, when it is not correctly being collected, can actually have a deep detrimental impact on the kind of care that can be provided moving forward. Wonderful. As suspected, a lot of folks on today's event are already on this topic. And I suspect that folks are interested in learning more, potentially maybe a little bit held back by their electronic health records, or maybe interested in learning more. Mike, do we have one more poll or before we move forward? Or perfect, wonderful. So here's our next poll, asking about if your clinic and healthcare organization provides training or resources on best practices around inclusivity and care to diverse LGBTQAI patients, clients that are relevant to sort of the services that you might be providing. And again, this sort of goes to this broader critical conversation we're having right now around, it's not enough to just be an ally. We must move forward and take decisive action. And what does that look like within the healthcare landscape? I think there's a lot of people, a lot smarter than I am, quite frankly, who can speak to what this looks like on the ground. And luckily we have some of those folks on the call today. Wonderful. Thank you so much, everyone, for participating in these polls. So speaking of folks that are smarter than myself who can answer these questions, I'd like to, direct this towards Barbara. Can you speak about how COVID is affecting individuals whose voices are not traditionally being heard, either broadly or within our healthcare landscape in particular?
Thank you. First of all, I want to say that it's very encouraging to see how many folks out there are actually collecting the data, and how many folks are in the process of trying to collect that data. And for all of those of you who are still struggling with that, feel free to contact me at barbara.warren@mountsinai.org, because we're happy to share what we're doing, how we're doing it, and support people in collection of that data. Let me also preface what I'm going to say, sort of focusing a little bit more on LGBTQ populations, to remind people, if you don't know this, or to inform people if you didn't know this, that particularly during Pride Month, some of you are probably aware, if not all of you, that the modern LGBT civil rights movement was sort of kicked off in the 20th century by what essentially was a riot, a huge protest in June of 1969 at the Stonewall Inn, which was a gay bar in Greenwich Village in Manhattan. In those days, police routinely raided these bars and routinely harassed, in a very brutal way, the LGBTQ patrons. This particular bar was a bar that really catered to a huge mix in the LGBT community, including people who were sort of called in those days street queens, and there was a large sex worker population, and there was also lots of different diverse LGBT people that frequented that bar. On I think it was June 28th, 1969, on a hot, steamy night, it just became too much for those bar patrons. The police raided. They were very brutal. They would bash people in the head. They would drag them in. They would throw them in jail for really no reason except just harassment. And that night, the LGBT community fought back. There's lots of stories surrounding who threw the first brick, but the reality is, what we know from history, is that a number of the leaders of what turned into a 6-day mass protest were people who were Black and brown people. 2 women of transgender experience, Sylvia Rivera and Marsha P. Johnson, were prominent in that. So it's really, to me, really sort of an interesting confluence of with what's going on now, that the LGBTQ civil rights movement and the anti-racism movement in this country really are intersecting. They're not 2 separate movements. They really are an intersecting movement, and Stonewall is part of the legacy of that. So that being said, one of the things we know is that COVID has disproportionately affected people of color, particularly people who are Black and brown. But we need data to support that, and we need to be able to mine real data to see and to support what those trends are, what's happening, what are some of the issues, what are some of the research that we need to do, what are the evidence-based practices and interventions that need to come out of that. And that is true also at the intersection of LGBTQI identity and other identities that people hold. So that's why it is so important to collect the LGBTQ data for us to understand how those populations, particularly at the intersections of race, ethnicity, socioeconomic status, age, et cetera, are being affected, and what the health disparities are and how we can learn from that. I will say that we do know, and there's a number of great briefing papers out there already from a lot of different national LGBT health organizations. We do know that LGBT people still are disproportionately high rates of things that will leave people more vulnerable to COVID, including diabetes, including asthma, including smoking. Some of the latest data on smoking, I even wrote this down so I could share it with you, is some of the general population numbers. 37% of LGBT people still smoke compared to 27% in the general population. We know that 21% of LGBT people report asthma compared to 14% in the general population. And as Dr. Kohal was talking about, and all of you I am sure already know, that HIV is still disproportionate in communities of color, and particularly among gay and bisexual men, transgender, and trans feminine women of color. We also know that violence, discrimination, stigma, prejudice, and murder, particularly for trans women of color, are at much higher rates. And all of these things can intersect with stress, and stress can intersect with health behavior, and health behavior definitely can contribute to how people experience their health care. And if you overlay COVID to all of that, we've got a lot of things to address. And I have colleagues here who I know this really well. I was there at the beginning of Harlem United, which started as the Upper Room AIDS Ministry, so I loved hearing you talk about the Upper Room AIDS Ministry. I remember when that started. That's how old I am. And so I think I really would encourage people not just to collect the data. It's not just a checkbox at Mount Sinai now. We've actually gotten some research grants where we're going to really do data analytics on this and look at the data that we're collecting, look at the granular racial ethnic that we've been collecting for the last 2 years, look at the SOGI data that now we've been able to collect across our system over the last couple of years, and look at those intersections and start to get a sense of what's going on, mining real data in the lives of patients, and to take a look at that and to see how we can both illuminate issues. And I just want to add, it's not just about finding the disparities, it's also about finding out what works. So we're looking to build the evidence space around LGBT medicine as well. And data collection is definite. Patient experience is an important part of it, the qualitative stuff, but so is the data. So I just wanted to sort of talk about that and make a pitch for that.
Thank you so much for that, Barbara. And I think that, what you just shared is really resonating with folks in the audience. We have, someone sharing, that what you just spoke about is really affirming, and really what everyone's spoken about thus far on today's webinar is really affirming that, everyone is together and trying to figure out how we can move forward in this sort of unprecedented crisis. And that, everyone's opinions, everyone's, gems of best practice is really what it's all about, around pulling together what the cross-section of information is going to be that continues to move us forward. So thank you for sharing that, Barbara, and thank you everyone else thus far. So Judy, we're going to pass it back to you again.
Thank you. So the next question is for Andrew Phillip, and it's kind of a two-pronged question. We know that the impact of COVID-19 on morbidity and mortality have been and continue to be staggering. But what about the impact of COVID-19 on mental health, and what are the behavioral health implications? In addition to that, if you could briefly speak about the importance of self-care, which you always remind us here at PCDC.
Great, thanks, Judy. I think that topic really resonates, particularly, listening to what Dr. Lawrence just described around the LGBTQAI population, around communities of color. When I think about the impact and the intersectionality of health, I think about things like trauma that's created by systems, even reinforced within the actual delivery of care that we provide. Long before this, this has already been happening. We see it in chronic pain and the provision of a whole bunch of different areas. So, that is like the first thing that I think about in this topic overall. From what is the behavioral health impact of COVID-19, we're still finding that out. We think that there's going to be probably like a 6 month or so or more delay, just based on what we've seen in past in disaster situations, really, in trauma research. And I think there's also just a lot of lingering concerns that those of us in the behavioral health community have. Dr. Kohal mentioned, concerns around substance use, isolation. There's already been this epidemic of isolation and loneliness, and now we kind of, confine people into small spaces. Again, bringing up concerns if you're not in a welcoming environment or a safe place. We have concerns around intimate partner violence and violence within the home if you don't have access to those traditional resources. And I think it's kind of to be determined, or at least validated, if there's impacts around suicide and other concerns there. And then we're really seeing this intersectionality of things like, again, starting to appreciate isolation. People are having to choose between their need for human contact and connection and their own safety. And uncertainty, and navigating this creates an immense source of stress. Talking about more vulnerable communities, we think about here in New York City, we do work out in East New York, out in Tremont in the Bronx. These are communities where people don't necessarily have the luxury, like many of us, frankly, of working from home, of kind of taking some of these safety precautions, and that takes a toll. That takes an additional stress. We talk about violence in the community, fear of, if I'm having a mental health crisis, do I have to worry about who's going to show up to my door to come assist me? Do I feel that the first responders are going to treat me fairly and safely? Certainly we know that sometimes that is the case, but sometimes not. So these are all having major implications around behavioral health, and especially for vulnerable communities. Depending on the diagnosis that we talk about, people of color, people who identify as Latinx, people who identify as Black, there's certain diagnoses like PTSD that they're already disproportionately suffering from, and now you crank this up with COVID, and again, kind of a worsening of this. So, I can expound on this for a long time, but you get the picture. It's the same kind of stuff that we were already dealing with, but wrapped up. So, thinking about like self-care, again, I mentioned, and I think this is relevant for our audiences here, I'm very, very concerned about healthcare providers themselves. We've been doing some work in this area, and I think a number of us are sort of partnering together. But, we have to take care of ourselves in order to take care of others, right? So monitoring burnout, we already saw providers with rates like 60% of burnout before COVID started. Just hearing the stories we've heard from today, you can see how that also amps up. So as managers, we saw that there's a lot of healthcare administrators and managers on the call today. Self-care really can really be foundational there, checking with your staff, seeing if their behavior is changing in more radical ways than others, but also creating spaces to talk about these things. making the conversation to involve, you know, your staff as far as what are their ideas, what are their concerns, and what would they find most helpful. You know, as individuals, I think, you know, I've been pulling people, you know, people are doing stuff like connecting with others through Zoom, exercising, meditating, you know, kind of a host of things like that as far as taking care of themselves. But also as a system, I think, you know, we can't ignore, as healthcare providers, even what kind of stressors our system creates. And so, you know, I think as we're navigating telehealth, as we're navigating Zoom-based discussions like this, we're having complex discussions around like integrating primary care and behavioral health virtually. As we're doing all these things, it's taking a huge toll on the providers, and there's a level of exhaustion for everybody, from dealing with your families to sort of finding new mechanisms for communicating. And so I think acknowledging that the one upside, I think, to all of this is that on some level, we are in a shared experience. And as a world, we have this opportunity to sort of like sit quietly or sit with injustice or sit with wherever we're kind of forced to sit and reflect, you know, is what I'm doing right now, does this matter? Is this how I want to use my time? Is this thing that's burning me out or exhausting me where I choose to divert my energy into in this moment? And I think that will ultimately be kind of the self-care that comes from this, is acting with intention, doing something that's meaningful. And I think today's conversation is sort of reflective of that. So this is like, I could talk about this for like 6 hours, but, you know, I think that's pretty foundational.
Thank you so much, Andrew.
Thank you, Judy. So Tamisha, I know that in your work, you know, not only are you the executive director and CPO of Upper Room's Aid Ministry, but you are also, if I remember correctly, the president-elect for the National Healthcare for the Homeless Council. I was about to say coalition there, it's council, I think. So I was hoping that maybe you could speak to this next question, that basically we are in a pivotal moment in history right now in terms of confronting racism and lack of access to healthcare, disparities and mortality and morbidity rates, poverty, homelessness, unemployment, the list sort of goes on. And so I'm curious around what challenges or opportunities even could the COVID pandemic be presenting to the individuals and organizations and communities that have been historically committed to addressing these issues and are presently interested in moving forward around addressing these issues?
So thank you, Kristen. Sure. Where do I start? You know, I'll start off by talking a little bit about what's going on across the country and then narrow down Harlem United. So it's interesting that during this pandemic and some of the actual killings that have taken place, we are noticing now that even our clients, some that were shy are speaking out and wanting to know why things are happening. And I have to say, due to racial injustice that has been exposed from COVID, more people, specifically people of color, have become more vocal and empowered to identify other systems that have demonstrated bias and engaged in racist actions. What does that mean? And I'm saying that because I must say that we not only have spoken to our clients about the concerns, but things have happened right in Harlem, and I'm going to go directly to what we see every day. So healthcare disparities for people of color, unemployment, difficulty assessing substance abuse programs, increase in domestic violence, really complex bereavement. People are dying and not even getting a chance to speak to people in nursing homes. We had a client that had a parent in a nursing home, couldn't visit, and got a call that the person died. How do you deal with that when you're already dealing with the day-to-day issues that you already have? And then, you know, to shift the topic, going back to disparities in the community, we face that on a daily basis here in New York, and I can speak for Harlem United. We have, we're in a very interesting time in Harlem. We have a clinic on 133rd Street, and we have a clinic on 124th Street. And if anyone has been in Harlem lately, the homeless population has increased in this area. We are seeing more and more people coming in with no insurance or undocumented, and then coming in with these other issues that now have been added, which getting tested for COVID. We have our harm reduction team out and testing, and we have been working through the pandemic. But to just talk a little bit about what's going on in regards to, and I'm going to have some examples and some data I wanted to share with you. So data shows that Black people have more underlying medical conditions, but crucially, they're not explaining why. We talk about this declines. They'll come in, how did I get this? And the response that some of our providers have, and actually we have a very engaged team, meaning from patient navigators to case managers, and they're trained to actually help with responding to a question like that. Or one of the other topics that comes up a lot, why are African Americans suffering more from chronic diseases? I have to say that, and I think everybody would agree with this, at this point in the pandemic, the disparities between the size of the Black population, the percentage of Black people infected with not only being hospitalized, but dead from COVID are very severe and high. I am going to share something that I read in the Washington Post recently. I don't know if anyone saw this article, but it definitely speaks on what we do at Harlem United. A Washington Post analysis found the majority of Black counties had infection rates 3 times the rate of the majority of white counties. Why? Should we be collecting this data? And I know Dr. Warren spoke about this a little bit, but I'm going to touch on it a little bit more. We should. On a national level at the council, I know that they're looking at this too, National Healthcare for the Homeless Council, in regards to, does the data show racial disparities, and why, if we are tracking it, why we're not hearing about it? And why are Black people generally being infected? I mean, is it the food that you do? These are the questions that come up, and I can't answer. I don't know if anyone else can answer, but we are sharing and educating our clients. What you hear in the media and what you see in the news from our providers to people around the country are still trying to figure all of this out. And then you read articles on, is this something that we can change? And I know we're on the ground here in Harlem doing what we can to meet clients where they are and keeping them engaged. Dr. Call mentioned earlier too, one of the things that we did recently, and Andrew mentioned it earlier as well, definitely changing the way we used to do things. We are noticing that not only having group sessions via telehealth, where somebody could be going through a trauma situation and not knowing that somebody else is, but now we have 5 people on the phone, and keeping those clients engaged. You never know who can change someone's life in those groups. So that's something we never did through telehealth. And we are seeing that people are asking for it. So we're having more groups through telehealth. And over at our day program, the topics that we talk about, it could be a topic on racial disparities. How can we change that? How do you think Harlem United can help with that on the ground? But I don't want to take up much more time. If anyone has any questions, I can answer them along the way.
Thank you so much for that, Tamisha. I think that there are probably a lot of folks that need to hear what you're sharing around this. And I think that as we talk about what our next steps are, which is actually sort of part of our next question, which is sort of the final plan question we have today, I think that, if anyone takes something away from this, it's the power of data. It's the power of saying, if we're not, we have to make things seen. We have to bring things up to become visible. We can't just keep acknowledging that things are happening. We need to really put our money and our electronic health records where our mouths are in regards to this. So thank you so much for illuminating that. So we are coming up on sort of our last couple minutes here for the panel. And, you know, we had this wonderful question and we wanted everyone to, you know, answer what they thought the next steps would be. And we wanted to have a big, long discussion centered to sort of regroup around hope and resiliency, as Henrietta sort of poised us for within this, this town hall. But of course, we're running a little short on time. So I do still want to capture that a bit. And I know that, you know, sort of the themes we've talked about today around, you know, making things visible, around, you know, different ways to do the same work, like the models of care that Allison shared, you know, different ways to engage with the folks that we're serving, to acknowledge that loneliness is a real and tangible motivator and demotivator for folks, such as, you know, that Dr. Kohal and Dr. Phillip touched on as well. So in these last couple minutes, what would folks say? You know, feel free to jump in briefly, sort of popcorn style. If you could, you know, say maybe 3 things that would be your recommendations for next steps, for how we can move forward as, you know, the healthcare landscape, as the leadership and folks that are our colleagues on attending the call today. What are the 3 things that you want folks to come away from this with, that they can do, you know, right away or maybe within the next few months? So hop in, folks. 3 things though, because we're running out of time. So sorry.
I'll go next. Is that okay? Okay, because I want to just relevant to what Tamisha was talking about. I think one of the things that we need to do is it's great to have a focus on the patient and how we can support the patient, but we really need to have a bigger and prioritized focus on systemic issues. And the systemic issues around minority stress and racism and even or lack of knowledge about and sensitivity to LGBTQ or whatever population that we're talking about. You know, one of the things we've been doing at Mount Sinai, and we've ramped it up, you know, at the intersection of COVID and the anti-racism, the new conscious awareness around it, ramped up our bias training, our anti-racism initiatives. One of the things that we know, oftentimes the high rate of health disparities in populations like LGBTQ and folks of color aren't because those patients may not have access to care or, you know, in some way don't adhere to care. It's because stuff is built into the system. We know that biases push back against people's ability to connect and get the same kind of care, even sometimes in less than conscious ways on the part of the provider. I don't have time to go into it. There's tons of research out there that supports that. We really have to rip that away. We really have to do things in our systems to promote and to encourage and to pipeline folks from communities of color into leadership roles in our system. And not as tokens, but as leaders. We have to deal with minority stress, which is societally experienced. It's not just, you know, an actual experience of bias, but the anticipation of having your head beat in by a white cop can send your cortisol levels sky high. And even when you have access to care, that can really affect your physiological health and result in a health disparity. Or if you're transgender and worried about getting on the subway every morning because you might get your ass kicked, so pardon my French. So those are the kinds of things we really need to begin to address and to deal with. And we need to do some systemic changes in our institutions around some of those issues, as well as support our patients and our providers. So excuse me for being passionate about it, but I feel really strongly about that.
And Kristen, I'll just do 3 words, and that would be tell your story. You know, this is a moment where it's been so clear that we need to hear from more people, and people are finding their voices, but it's also getting that systemic issue, telling the story of what you're doing now. How is your healthcare system, your clinic, you as a human being gotten through this? Because this could be a pivotal changing point, or it could not be, right? And so much of that is, you know, we've got data and everything, but we need to hear people's stories. You know, I would say to anyone on this call, if you don't feel like you have a voice, let us help you, you know, but I think that's really like anyone and everyone can be doing that right now.
Thank you. Any other panelists, sort of the quick 3 things or one thing you want folks to take away?
I think what's been amazing to me over the last several months is how rapidly things can change. I mean, last week we celebrated Juneteenth, and how many corporations and how many governments, how many academic institutions gave employees a holiday off to recognize the significant moment in time. We've seen mega institutions such as the ones that I work at, the ones that Dr. Warren works at, the ones that Tamisha works at, and so on, make proverbial changes on the drop of a dime, implementing telehealth, for example, things that have been on the shelf for years, but within the space of a week, as Tamisha mentioned, things got done. So I think the passion, I think the energy, I think the anger, I think the excitement needs to be mobilized to keep the pressure on, to not just, think about the flavor of the moment, but what we can do consistently to chart a better course for our clients and our communities. I think one of the things that is really so important, and I'm glad we have behavioral health folks on the panel today, is to really forge a tighter and more integrated approach to working with patients and not segment them as has been the typical medical model. So if anything comes out of this, I'd like to see that closer working relationship in a more thoughtful manner between the most important people in the healthcare delivery system.
Thank you so much for that.
I can just add, this is Tamisha. I would say to continue this conversation. I know it's a topic, this is a town hall. I'm not sure what each agency is doing, but diversity and inclusion trainings are like, it's a big deal, and it should have been happening. And if it's not, it's definitely the right time to do that. Continue having conversations that may not be comfortable. It may involve clients, more focus groups, really. And I want to bring this up. The one bigger issue that I think we have too in organizations are not, and I'm saying not Harlem United specifically, but in general, are topics that may not be discussed but thought about. And now is the time to do that in regards to disparities, racism, and how do you deal with that? I mean, the average agency may not even have the internal talent to do it, but investing in that. And last but not least, I will say, the pandemic has also enlightened our need to be better prepared for a crisis and working together internally and externally. It was amazing to see what we did internally, but I can also say it was amazing to see what we did with the hospitals that we never done before, and to continue that. It shouldn't take a pandemic to bring everyone together to change lives in the community, if that makes sense.
That absolutely makes sense. Thank you. And again, last but not least, Allison, any key short and sweet takeaways for folks today?
Yeah, I think one disparity that became so apparent during this is the lack of access that patients have to even something like a phone capable of doing video. So I think from a policy standpoint, just being able to continue to push for coverage of a telephone visit while a video visit would be optimal, some patients just aren't there yet. I think the second thing is that even though we may just make a telephone call, just a telephone call to a patient, I think providers need to look at every encounter with a patient as a chance to make really a difference in their life. So whether it's spending 30 seconds more on education, explaining why, if they stop smoking, all the positive effects that potentially they could have. And lastly, I think innovation. I think this is another opportunity for us to really push innovative changes very quickly. And we could try to figure out the best and most effective way to engage patients and reach patients and try to encourage the group visits, similar to what a lot of people mentioned already today, but just using it as an opportunity to drive change.
Thank you so much for that. And really just thank you everyone so much for joining us and sharing your guidance, your wisdom, your expertise, your own lived experience as leadership within this amazing healthcare landscape that so many of us love dearly and work every day to try to be better within. And with that, I want to pass this back to Henrietta.
All right, great. Thank you so very much. We really appreciate this wonderful conversation. So if we can just go to the next slide, as you can see up here already in terms of next steps. And I think a lot of us have already talked about this already in regards to next steps. In terms of, what can you do? And just a couple of key points, and I think we've already kind of talked through some of them already, in terms of what can you do in your organization. And I think it was already mentioned by our panelists to, if you haven't started already, begin to have honest conversations with staff about what's going on in our communities. I think it's very key to be able to do that. And definitely seek outside support to have those difficult conversations around race, around structural racism, around communities that are more impacted on what's going on, what's around COVID and all the other issues that we talked about. And definitely being able to get support from leadership is necessary and key. I think Dr. Al Pohal mentioned, you don't want this to be kind of like the flavor of the moment. This has to continue. You want to continue the momentum. And this is supposed to be something that you do as an organization. So that's something that we want to also consider. And then what can you do as a community? What can we do collectively as a group? We can't look at ourselves as silos. We have to be able to see what and how we can support one another. And one of the things that we can do is definitely listen to the voices that are unheard, being empathetic. We've heard the word ally that, through different ways in the last few months. How can you be an active ally? What are you doing actually? And be supportive, in regards to specific actions. And then last but not least, how can PCDC support you? We'll be sharing a list of resources with all of you. There will be a number of opportunities where you can also go to our website and see what else we can offer you, as well as being able to reach out to any of us, our panelists, as well as folks at PCDC, if you have any additional questions or you need additional support. And before we close out, I want to just throw it right back to Judy and Kristen. I think we have a few more moments. I think we want to just see if there are any specific questions or comments that were in the queue. I'll turn it right back to Kristen and Judy to see if they want to grab any of those questions or comments folks have shared. Thank you so much.
Judy.
Thank you so much. Thank you so much, Henrietta. In the interest of time, I sadly don't think we have time for the questions, but I do encourage everybody to please send your questions and we'll save these and help us figure out the next steps in this conversation and how PCDC can work with the community and healthcare organizations. I do want to say that we've had many wonderful people chat in fantastic comments about how important it is to have conversations like this, to talk about racism and to talk about, and how enlightening the meeting has been and a reminder of how important data is for bringing things out and making visible the things that can change. And, I just want to say that personally, I could have sat and listened to these panelists all day, and we can definitely consider doing it again. So we want to thank you so much for that. And just hope that we all continue these conversations and make a commitment to continue the conversations. Anything else that anybody wants to say in parting?
I think just one last thing to say is that we have evaluations, as Sarah Jane mentioned early on. So we will really appreciate folks that at the end of our webinar, you will be getting a link that will also include a link of resources. Please complete the evaluations. We would love to hear from you in regards to what went well, what we could have done differently, and would you like to have something like this in the future? So we will really appreciate it. And again, thank you for all our panelists, for all of you for sharing and this wonderful conversation that we had.
Thank you.
So on that note, I think we're gonna end it, okay? I think we are done for today. Enjoy the
Thank you, everyone.
afternoon or wherever you are today. Thank you, everyone. Be safe and be well.
Thank you very much.
Thank you.